Hello everyone, we'll talk about an interesting topic today. Again, I'm Ali, one of the Pediatric Residents at Texas Tech, El Paso. There's an interesting topic I was reading about, and I thought I best learn it and best think it through teaching. Most of those lectures that I do, most of those recordings that I'm doing are mainly the way I try to understand things more and the way I share things with people. So the topic about this is an article I read that was published in The Lasting Legacy of Intensive Care Medicine, and it came with the title of Everything You Need to Know About Deresuscitation, and I believe it was published back in 2022, so that was last year. So basically, this interesting topic first discusses what is fluid stewardship, right? So all of us know about what is antibiotic stewardship, but here we're talking about fluid stewardship in itself. And the term deresuscitation, based on this article that we read, was started back in 2014, and basically they were trying to define that there was active fluid removal from these patients when they are overloaded, whether by using drugs or ultrafiltration or by just basically deresuscitation, de-escalating of whatever you're using. However, they prefer the term de-escalation because it relates more to reducing the amount and the rate of the fluids you are actually giving. So when they came to define what would be an overload, a fluid overload, they said it could be defined as about 10% body weight fluid accumulation from the baseline weight that the patient came in. And they started to suggest that we should avoid the term fluid overload because it can be misleading, because it can tell you, fluid overload basically means that the patient has intravascular hypervolemia. And they were like, okay, so we suggest that we use fluid accumulation instead of fluid overload in this article. Basically because they're saying that a fluid accumulation can happen regardless of the fluid balance that the patient is having. So a patient can have intravascular hypovolemia, normal volemia, or hypervolemia, and that may or may not be associated with whatever we're seeing as interstitial edema. So basically when they were talking about this, they said, okay, so there is a fluid stewardship that we need to know, and every physician who is administering fluids, who knows that fluids are actual drugs that we're using, we need to know the 4 Ds of it. And the 4 Ds that they wanted to discuss was drugs, what kind of fluid are you using, dose, how much are you giving, and duration you're giving it for, and when to de-escalate. Remember, this article is not pediatric article, it's just a concept of deresuscitation in intensive care unit, but we need to understand that fluid intervention is one of the most common interventions that we use in medicine, period. It doesn't have to be an intensive care unit. So that being said, they said, okay, so you need to ask yourself 4 questions. You need to ask, when are you going to start the fluids? When are you going to stop the fluids? When are you going to start or stop that fluid removal that you're building? And that led to, okay, so what are the indications of us, as a very broad term, what are the broad indications for fluid resuscitation? So they said for fluid administration, which is resuscitation, maintenance fluids, replacements, and nutrition, right? And then they went, okay, so in order to apply this, we need to apply a model. And that model they called the Rose model, because it consisted of 4 phases: the resuscitation phase, the optimization phase, the stabilization phase, and the evacuation phase. And basically, the good thing about, they had a very good diagram or graph that explains it. So as you can see here, the resuscitation phase over here, it's a life-saving phase, And mainly it's about us rescuing the patient within the first golden few hours. And this is an escalation of the fluid volume that you're giving. So this is a graph of volume over time. So basically in the first minutes to hour, you want to resuscitate that patient. And EAFM means basically early adequate fluid management that you're giving that patient. Then once you hit that phase, you need to understand you're optimizing your resuscitation at this point. And this phase is focused on what we mentioned is the maintenance that we're giving. And we need to avoid that fluid overload that can happen here and lead to something called the fluid creep, because we're not noticing, we're not paying attention to how much are we giving, our balance. And this is basically aiming for a neutral fluid balance to be given in here. And the term LCFM, they said it's a late conservative fluid management phase. So here we start the escalation of the resuscitation that we started initially. And then this phase is the evacuation phase, where you focus on organ recovery from all of the fluids you gave. So this is more of an active late goal directed for fluid removal from that patient. And you, at this point, you're resolving whatever fluid overload, if you have any, and you're deresuscitating the patients. And it can cause over weeks, but it depends on the duration that you're having. And the good thing about here, they kind of gave you parameters of what to look for. So initially, when you're resuscitating that patient, you need to see that your IV fluids, if you're in shock, you look for your MAPs. And in pediatrics, that's completely different because it's based on age group. We usually aim for 35, 45, and more than 65. And then based on age groups, that's a different topic. And passive leg raise test, whether it's positive or not, what you're giving the patients for perfusion index and the CVP pressures, and optimization, you're telling you what am I looking for triggers to stop the IV fluids. Are you looking for your lactate? Is it starting to be lesser than 3, so lesser than 2? Once you're positive, your intra-abdominal pressure being less than 15. And all of these are parameters that they put together to differentiate the different phases that you're having here. When we talk more, you'll see that we're aiming for, in resuscitation, to reverse the shock. And then in optimization, we want to make sure we're starting to stop the fluids, because at some point, the fluids that we're giving, the body becomes unresponsive to the fluid that you're giving. And then in this phase, when you are actually evacuating or removal of the fluid overload, you want to make sure that you don't hypoperfuse those patients. So that was the ROSE model that they were discussing, which is a very interesting visual model that they had. That being said, so they decided, okay, when is the best time for me to start deresuscitating the patients? And he said a good clinician would start deresuscitating patients once you start resuscitation. So once you start resuscitation, you have the endpoint in mind, and you want to see, okay, I will de-escalate at this level. I will start looking at certain parameters, and these parameters are going to tell me, okay, now it's time for me to pull back, to go down, and I need to keep an eye on it so I don't miss it while I'm aggressively fluid resuscitating a patient. Don't get me wrong, when we're resuscitating a patient, it's life-saving. Here we're thinking of de-resuscitating, which basically, after you already stabilize that patient, so what can we do to prevent iatrogenic damage from the fluids that we are giving? And here is mentioning, so fluid accumulation. How can I measure fluid accumulation parameters? So if you have a positive balance, if you have increased weight gain that we discussed initially, where you look at your initial baseline weight and what happens from now, or your labs have hemodilution, looking for certain radiological signs. So when you do an ultrasound of the chest and you see that B lines, which is basically a sign of fluid in the interstitium of the lungs, you're looking for pleural effusion, looking for the inferior vena cava have decreased collapsibility because of that fluid overload in it when you're looking at the ultrasound. And then looking at something called altered cardiopulmonary function, which is basically one we mentioned that the body is no longer fluid responsive. There is increase in your pressures. There's increase in your volume preload. There is decrease in your pulse pressure variations, and all of that basically is telling you that you're overloading the body. They also had a very good image for it in the article, which I'm gonna reference in the end of the video. As usual, it's an open source article that you can reach at any point. There we go. So they're looking for, okay, what are the signs that you can see clinically? So abdominal wall, you can see tissue edema in the patient, you can see poor wound healing, you can see wound infections, pressor ulcers, decreased abdominal compliance. You'll see cerebral edema, increase in the ICPs, intracranial pressures, or your CPP, cerebral perfusion pressures. Intraocular pressure increase, respiratory LC pleural effusion, edema, there's hypoxia and there's increased hypercapnia. And then you'll see renal interstitial edema, you'll see hepatic congestion, you'll see gut edema, malabsorption, increased abdominal pressures, cardiovascular, you'll see myocardial edema, which basically you'll see increase in central venous pressure, you'll see decrease in venous return, you'll see decreased cardiac output and decreased myocardial depression, and increased myocardial depression, and you might see pericardial effusion basically. That being said, they were like, okay, so these are the signs that we need to be aware of. These are the signs that we need to look for. So how can we deresuscitate these patients? And basically they said when we want to deresuscitate these patients, we need to, one, prevent. So we need to give fluids but restrict it. We are knowing how much we're giving. We're not giving it haphazardly, and we know when to de-escalate. And per the article, they had percentages for the amount of fluids that you think you're giving to that patient. They said there's 6% are usually in your resuscitation phase, 20% of it goes into your maintenance IV fluids, but do not neglect that 66% where it goes to nutrition or drug administration. And that nutrition parts, whether it's TPN or you're giving different nutritions, or the drug administrations for the carrier fluids for the drugs they're giving, or through every single drug administration they're giving to the patients, which will cause that fluid creep, basically. And they had a whole table in the article that you should really check and read in the supplementary materials for that article. And it sums up well, but again, these numbers and parameters are different than the ones in pediatrics, okay? They're telling you look for your monitoring, look for your metabolic optimization, when to give. So you want to increase your renal blood flow, you want to decrease your filtration fraction, make sure you're reducing the lymphatic flow of your patients by giving vasodilators. And remember, looking at that graph, now we're at the phase of weeks in admission of the ICU or days in the admissions of the ICU, and you're trying to deresuscitate everything that you did. If you want to give inotropes like Miller-known, if there's increased heart pressures increasing, how to lower your intra-abdominal pressures, and how to combine therapies of diuretics to decrease it, and knowing what will happen when you give loop diuretics versus acetazolamide or thiazides or potassium sparing. It's a very interesting combination that we won't go through here as much, because basically if you're here already, you know the function of these drugs as a concept, but it takes a very meticulous measurement to understand your drugs, how they work, and how are they going to affect your fluid balance and your fluid compartments in your body when you're deresuscitating your patients in the ICU who has multiple comorbidities regardless. And then when to stop their deresuscitation is usually when you reach the goal that you set for yourself in your management plan with your multidisciplinary team, when you have a good clinical based on your good clinical judgment, and that's an adequate deresuscitation that you're giving to the patients, or during your deresuscitation phase there's a clinical instability that you need to backtrack and fix differently. I think this is an interesting topic that people know about but not know about in a way, or at least I didn't know about. Again, this is just my understanding of this article, which was interesting for me to read. I'll read more about it. I wanted to explain the concept, not the numbers, because the numbers in itself differs from adults to pediatrics, and I'm more interested in, not more interested, I am in pediatrics, and I'm more interested in pediatric intensive care. So yeah, that's it. If I misunderstood something or misinterpreted the article, I have it down in the references and the resources. Just always let me know, and we can always modify and improve, and we are learning together. So yeah, thank you.